I'd like to call the meeting of the Speech Language Pathology Practice Committee to order. We'll call roll.
Debbie Snow, public member.
Patty Solomon Rice, Speech Language Pathology member.
Dee Parker, Speech Language Pathology member.
Paul Sanchez, Executive Officer.
Kelsey Pruden, DCA Legal Counsel.
Okay. Do you have minutes?
Do you want me to?
Okay.
We can actually.
Yeah, well, we can.
We need to ask if anybody else wants to introduce themselves.
Okay. Would anybody else like to introduce themselves at this time?
Humphreys, Operations Manager. Karen Chain, Public Member.
Patrick Lake, Department of Consumer Affairs.
Just concerned with this meeting.
Harley Newman, Board Staff. Nathan Carroll, California Attorney General.
Got everybody?
Yes.
Okay.
You can go ahead and hand it over to Pat. Yeah, sure.
Okay. At this time, I'll turn the meeting over to Patty Solomon Rice, who is Committee Chair of the Speech Language Pathology Committee.
Great, thanks. So I think all three members of the committee are here, so we've established a quorum. And the first order of business is to approve the February 8th, 2018 minutes of the Speech Language Pathology Practice Committee. So, I'd like to have a motion to approve the minutes
I so motion.
and a second.
I second.
And do we have any changes or additions to the minutes at all?
I didn't.
No.
Okay, so how about if we go ahead then and have a vote? All of those, oops, public comment for the minutes of the Speech Language Pathology Practice Committee? Okay, seeing that there is no public comment, we can go ahead and vote then? Okay, so let's go ahead and vote. All of those in favor of the minutes? I think we need to go by individual, is that right? Or can we just vote?
roll call.
Okay,
I, or I approve.
I approve.
I approve.
Okay, and since that's the three of us, there cannot possibly be anybody opposed or any abstentions, so the motion is passed. Next, we have public comments for items that are not on the agenda. Any public comments for that? Seeing as there are none, we can go ahead and move on to the items on our agenda. We have two items on our agenda: discussion and possible action regarding required professional experience direct monitoring requirements and remote or telesupervision. And what I thought I'd do is just briefly go over the reason why we're having this discussion, and that is because we received 3 letters addressing those particular issues. And I'll briefly go over what the 3 letters are. Then I thought we'd review the regulations and then have some discussion on particular items.
Excuse me, Patty, can I just point something out too? We have received additional letters since that time. They came in a form letter, and the content was similar to what we already received, so we didn't have time to summarize those. But
Okay.
we received at least 7 more letters, right, Brianne? 6 or 7 more letters.
Okay.
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 I just
well-
wanted to point that out.
Okay, great. Well, I'll summarize the information that we received prior to those 5 letters. So one of our letters was dated March 2nd of 2018, and it's from Holly Kaiser, who is CASHA's ASHA State Education Advocacy Leader. And so she's a liaison between CASHA and ASHA regarding state advocacy. And her letter, in a nutshell, discussed some confusion about when we can or cannot use telesupervision What she was particularly interested in is some website our website and our verification form use direct supervision and on-site direct supervision in describing what can or cannot be considered telesupervision, but neither of those two terms, direct supervision or on-site direct supervision, are in our required professional experience regulations. So that was her concern. She wanted us to flesh out whether direct supervision means that the individual is physically in the same location. And if these should or shouldn't be used when in fact that information is not in our current regulations. So that's one issue. Then we received a second letter from Seth Mukai, who is the Director of Schools for Advanced School Staffing. So that would be a business, a speech-language pathology business that contracts to schools and provides speech-language pathologists in schools. And this individual's concern is that at this point, they are unable to provide supervision of clinical fellows who work in schools remotely. And her letter went on to discuss the advantages of remote supervision and that remote supervision is increasingly widespread in the United States. She mentioned that they currently provide telesupervision in 8 states, and they have had clearance from other state boards to apply to provide telesupervision for another additional 12 states. She wanted us to consider offering the possibility of telesupervision for, she referred to clinical fellows, but of course in our state licensure, they're called required professional experience in California. So that is a second letter that we got. And then a third letter that we got was from Selendora Tremper, who is a special education coordinator for Springs Charter Schools. And she is also a speech-language pathologist. And she was writing to support the use of telesupervision to satisfy the direct supervision requirement. She went on to state in her letter that there are staffing shortages because we do not allow for direct, because of the requirement for direct supervision of clinical fellows, again, through our licensure, that's required professional experience. And she wanted us to support telepractice as a supervisory mode for both required professional experience and for speech-language pathology assistant supervision. So they're all along the lines of can we provide telesupervision for our required professional experience and for speech-language pathology assistants as well. And the first letter being she couldn't find anything that really stated in our regulations that we could not. So that's what we're here to discuss. I thought next we might talk about what the current regulations state. And what the current regulations state, you can find in our information from Paul. And it discusses Regulation 1399.153.3, responsibilities of RPE supervisors. And what those particular regulations state is that supervision consists of direct monitoring for a minimum of 8 hours per month for each full-time required professional experience temporary license holder and 4 hours per month for each part-time required professional experience temporary license holder. Direct monitoring addresses personal observation with at least 50% of the supervisor's observation in the area of evaluation, assessment, and treatment procedures, et cetera, et cetera, et cetera. However, our direct monitoring of personal observation does not include any definitions for immediate supervision, and there are no definitions for indirect supervision. And so we really haven't defined what those terms actually are. So that's something for us to consider. That's what Holly Kaiser, I believe, was addressing as well. So, so I think what's important for us to discuss is that first of all, I think we need to define what direct monitoring means. And then, do we want to change our definitions to match those of the speech language pathology assistant definitions, and we can go over those as well. And then we also need to have a discussion of, do we even want to support telesupervision? So there are two things. We need to talk about the definition of direct observation, and then do we support telesupervision?
You know, one other thing, Patty, that we might also want to discuss is a requirement for 8 hours of supervision, because I understand ASHA has a different requirement
Okay.
for the RPE. So that's just something that you may want to consider.
Do you want me to mention what the requirements are for the
Sure.
ASHA requirements?
Yes, please.
Sure. So what ASHA requires, ASHA divides the equivalent of our RPE, which is a clinical fellow, into 3 different 3-month segments. And each of those 3-month segments, the individual needs to be observed for, I'm going to get myself confused whether it's 12 hours or 18 hours. I would have to take a
But
look.
I think it comes out to 4 hours a month, right?
Okay, then
as
it would
opposed
be
to 8
12
hours. Yeah,
hours
yeah.
total. So for each 3-month segment, the individual needs to be observed for 12 hours, and then they receive a scoring system from numbers 1 through 5. That's actually being modified for 2020, but for right now, there's a scoring system based on 1 through 5, and by the final 3rd segment, of 12 hours of supervision, they need to obtain a score of 3 or higher based on a 5-point system. That's what ASHA does right now. So that's very different from what we do. But at any rate, do you want us to talk about the definitions right now? Or how would you like us to proceed?
Well, I think a couple of things to consider. In your board materials, I shared with you the definitions that do exist
Yes.
for speech language pathology assistants.
Right.
Now, the reason I shared this is not so that we take one definition and apply it to another, but just to give us context. When we look at direct monitoring, when the board staff has looked at that, we base it on our current definition of direct supervision, because when these regulations were written, telesupervision probably wasn't an issue, probably wasn't something that we were doing.
Yeah.
So I wanted to point that out. We do have in our SLIPA definitions, indirect supervision by electronic means.
Yes.
And then Kelsey just pointed out earlier today that in our proposed regulations for direct supervision, we also include by electronic means.
Mm-hmm.
So that's something to keep in mind. We are actually proposing this for SLIPAs, so I don't know, would there be reasons to want to restrict direct monitoring to not include telesupervision?
Well, I think the difference here is the regulations that we're proposing for SLIPAs are not when they first start being a SLIPA.
Mm-hmm.
They are for after they have been supervised and verified by their supervisor that they can do the duties and responsibilities that they're assigned to do. The RPE is a different animal. The RPE is a person who's just completed their master's program and is being supervised because they've just completed their master's program and they are now being employed in a potentially new setting, in most instances, a new setting. So I think there are different kinds of animals that we're referring to. Once they've completed their RPE, then they aren't going to have any supervision. They can do telesupervision. They can do pretty much anything they want that they are trained for, and have confidence that they can perform adequately. But to me, an RPE is really different.
Okay.
So when we look at the SLIPA definitions do have direct supervision, which, and they have immediate supervision and they have indirect supervision. And indirect supervision can absolutely be provided by electronic means. Direct supervision is when the supervisor is physically available but not necessarily physically in the same place as the SLIPA. Immediate supervision is when the speech language pathology supervisor is physically in the same place with the SLIPA. So those are the two different definitions that we have. I think what we need to discuss is, do we want those same types of definitions for our RPE supervision? And if we do, how are we going to use those for the actual supervision of the RPE? I don't know if we do or don't. It's a change. But right now, our direct supervision isn't as explicit for the RPE.
Yeah.
So what is everybody's thoughts on that?
Consistency. I think the closer we can get to consistency, the better it will be for everybody.
Yes.
For the supervisors, for the people who are being supervised, and as they pick up any of our written statements, then they understand, and we are at least consistent and using the same terms.
Yeah, well, I would completely agree with that we should have consistency rather than inconsistency. So,
In talking to Mr. Mukai, talking to Ms. Kaiser, I believe, Holly Kaiser, they both referred to ASHA standards, and I think they talked about telesupervision in both RPEs, but also in dealing with SLIPAs, and that ASHA made statements about telesupervision. I can't quote them right now because I don't have them in front of me, but if we're talking about being consistent, then I think we want to consider what we are proposing for SLIPAs today. And what we are proposing for SLIPAs today is that direct monitoring or direct supervision would allow for telesupervision. And that means that if we were to apply that and propose regulations for the RPEs in that same manner, that there wouldn't be restrictions for telesupervision. So just keep that in mind. When we're talking about consistency, that's what we would be proposing.
although our SLIPA regs also discuss the importance of immediate supervision during the first, I think it's the first 30 days.
Right, and I'm just talking
Yeah.
about the direct supervision aspect of it.
Yeah,
So we would have to maybe, if we were just talking about direct supervision and applying that to direct monitoring, there would be no restriction.
yes. So, yeah.
You talked with them, Paul. Do they want stronger
That-
verbiage that really sets forth
I-
exactly what they want? Or is this where we're looking to be consistent among ourselves,
I think
our board?
they have very compelling reasons for why they would like to see the RPEs able to be supervised, able to be telesupervised 100% of the time with no restrictions. That's the message I'm hearing.
All right.
Okay, well, that message is not the message that the ASHA Council for Clinical Certification is giving.
Okay,
Those two are not matching
okay.
because,
And that's what they're saying in their letters, right?
yeah.
My-
Well, I don't know what,
what is that council proposing?
What the Council for Clinical Certification proposes is that if individuals are interested in completing telesupervision, there's specific information that needs to be provided to the council as to where, how confidentiality is going to be served, how many hours, what percentage of the time is going to be telesupervision, and it's all reviewed on a case-by-case basis. So what the business wants and what is actually in practice right now are two very different things.
Are those two communicating?
Yeah. I mean,
So they're actively working with Action on this. As they've
well,
asked
that's
us
what the
to do as
regulations
well.
are for CF. That's what it states for, that's
Right.
what the standards state for CF, and that's what
Right.
the forms state.
Right. And is the business side going along with it?
They have to.
Right, but are they asking for something different?
Yes, they certainly are. Yes.
I have a question for the committee. So currently in 1399153.3, under direct monitoring, it lists different tasks that must be directly monitored. So my question is, in moving forward with consistency and talking about the telehealth, are all of these tasks ones that you feel could be done by electronic supervision, or are there certain tasks that may require actual physical presence?
So are you referring to the RPE or are you referring to the SLIPA?
RPE. So right here it says,
So
direct-
the scope of practice for SLIPAs is completely different than
right,
the scope of practice
absolutely,
for RPE.
absolutely. So that's why I'm asking about, because I know and working extensively on the SLIPA
Yes,
regulations.
they're really different.
That there are certain tasks where the board has decided that it isn't proper to use that sort of supervision. So I'm asking for under 1399153.3 D, and then it lists 1, 2, 3, 4. It says evaluation and assessment procedures, treatment procedures, record keeping, evaluation or assessment reports, correspondence, plans for management, and summaries of case conferences, participation in case conferences. At least 50% of the supervisor's observation shall be of the RPE temporary license holder's evaluation, assessment, and treatment procedures. So my question is, are those tasks, can those tasks be monitored or supervised electronically, or do they require an in-person supervision?
Well, I would say that really depends on the skill of the RPE. Some RPEs are perfectly capable of that, and some RPEs need more hands-on care and direction and modeling. And it really depends on the RPE. I don't think we can make can we make a blanket statement like that?
I wouldn't want to.
Yeah,
I would really hesitate doing that.
yeah, I mean,
So your thoughts would be more along the lines of that the supervisor would be in charge of determining when electronic supervision is necessary and when it's not.
well, when it is and when it's not based on convenience. I mean, that's my biggest concern, is that it not be based on convenience.
Right. Versus the SLIPA model, which is based on certain tasks.
Yes.
Okay, so I'm just trying to understand.
Yeah.
I don't pretend to have a lot of knowledge in this type of training or how it's set up. So I'm just trying to understand so that I can assist. So the SLIPA model is more along the lines of these are the different tasks that we have determined can be electronically supervised. And then these other tasks, we have determined you need to be physically present, you need to be there, there may be a patient safety issue. No matter the skill level of the SLPA, the supervisor needs to be present in the room. So, but it sounds like that's not necessarily how the committee sees RPE license, temporary license holders, that it's more based on their skill level and a supervisor being able to determine what functions, and it may be all of them, that this particular individual can do with the supervision being by electronic means versus not. And it may mean that some individuals are always supervised electronically and some individuals are not. Is that what?
It could be if the RPE temporary license holder was really skilled and had a lot of experience in the particular type of, or had some experience in the type of caseload that they were working with. So that's why it's really hard to.
So does this mean some type of statement in the regulation that says that a
So-
supervisor could?
So give me a minute to take a look at this, at the governing statutes to see what authority the board has in determining that. Let me take a look real quick.
Yeah, this is, quite honestly, this, because of the limited scope of practice of the SLPA, it's really a lot easier to talk about it in that way. But there's really no limitations to the scope of practice of the speech language pathologist other than to have some training and experience in particular areas of which they are getting as the RPE. Well, the other thing I was thinking is, do we feel that we need, do we want more information on how ASHA handles the type of telesupervision aspects of the CF, which is the equivalent of the RPE, or is that not needed? Is that something you think would be important for us to have or not? I mean, we're not trying to repeat.
Right. By repeat, you mean duplicate?
Yes.
Yeah, right. I think it's important to know that, but I also think that, this information that we are being given, provided with from these other interested parties, I think are really important to consider.
Yes.
We may also want to look at it from the standpoint of workforce development. Are we creating any type of workforce or licensing barriers by being more restrictive than what the national standard might be? And I'm not sure I'm not saying that that's the case, but are we being more restrictive? And if we are, that may be an important factor to consider in today's climate. Are we creating some type of barrier? So we want to look at it from that standpoint too.
And I think there's always a give and take between workforce barriers and consumer confidence and
Right.
and capability, and
Right, and that's our highest priority, consumer
So,
protection.
yeah.
That outweighs the other. That I want to be really clear about that.
Yeah.
But I think that the barrier of a potential licensing barrier and workforce development are also factors that need to be considered. And that's where these letters are really important to look into these situations more and look at the factor of a shortage and that kind of issue.
And that's why I think it's so hard to make these decisions because, as I say, it depends on the competency of the speech language,
Right.
the RPE speech language pathologist. It really depends.
And historically, this was a decision. This was a policy decision that was made, years ago. But I think that in moving forward, it shouldn't just be a policy decision. It should be something that is in regulation that's clear, so that there's clarity out there and people know exactly what the board expects. There was some confusion at our last meeting because I said depends on the situation, but we were talking about RPEs and we were talking about SLIPAs when we were talking about telesupervision, because the board has been consistent in how they deal with the two. But I think it's not clear to people that are out there, because the people that are reading the regulation are saying, okay, well, what does direct monitoring mean? And they don't know the background behind it. So is this something that you think you need to maybe work on more with the committee and with legal counsel?
I would say you don't hear a lot of talk coming out of the three of us
Okay.
right
Yeah,
now, so
it's-
that would suggest yes.
And I don't
Yeah.
think we need a motion for that, right?
Unless you want to and you can motion to have, staff, come up with more documentation or, put it on a future meeting, yeah, no necessarily for a motion.
I know that there are also people out there that are probably feeling a sense of frustration.
Yes.
And I think we're definitely taking that into consideration. We want to move, try to move quickly with this. So I think that we can accomplish that and come up with something by our next board meeting.
Okay, so what do you suggest that we need to have for the next board meeting so we can speak more eloquently on all of
I think
this?
that's really difficult to determine at this point, but I think we're on the right track. First, Kelsey has some legal research that she probably has to do to make that determination. We're looking at a couple of different models, but without speaking prematurely on it, I think that we definitely need to come up with some proposals and maybe get some feedback initially from interested parties that are out there.
So when you're talking about some legal models, are you talking about legal models that other boards use right now? Is that what you're referring to, or are you looking at, what do you mean by?
Well,
legal
I think you may, what I'm saying is, there's a suggestion, there's the current model that says everyone is direct monitored, and direct monitoring either includes or doesn't include telesupervision.
Mhm.
But then there's another model that says it's up to the supervisor to make that determination based on the person's experience or qualifications. And that's something different that would require probably a different type of structure.
Okay,
That makes
Well,
more
I
sense
think
by
that-
direct. and
yeah, I mean, I think
It
really,
does or it doesn't.
Right.
Now we've got clear cut lines, and that's what I think you're looking for across the board here. Do we have those clear cut lines?
yeah, and I think probably the two of us are interested in it's up to the supervisor, but when it's up to the supervisor, it really has to be based on the skills of the RPE, not on the convenience of the supervisor. That to me are two very important issues.
Right.
So why don't you make a motion to direct staff to work with legal counsel to come up with a proposal that models the telesupervision as a supervisor's decision that's based on the RPE's skills and not on convenience.
All right.
Would
Can
you-
we say so moved using your
Well, no,
words?
I just make suggestions.
But yes.
So
I would
that
just, and I would just state it in the, without the, and not on convenience, because I
Well,
think
that's a
that
terrible
by
term,
the
yes.
affirmative, by the
Yeah.
affirmative statement, you're already saying that.
Yeah.
Yeah.
Right, exactly.
Mm-hmm.
Well, okay, do you want to go ahead and move that,
Okay.
Deary? Or Debbie, would you like to move that, or?
I think one of you could speak it more eloquently than I
Oh, the
can.
elephant's there.
Yeah.
I agree, but
I
Okay,
like the way you said it.
yes.
all right, so how about if,
Do you want to
So-
repeat the motion?
Uh-huh.
What
The-
Kelsey's-
recommended motion would be to direct board staff to work with legal counsel to create a proposal of language based on the model of telesupervision where it is determined based on the skills of the RPE.
okay. Okay, so we would like to go ahead and move that. And just to
Are
state
you
it.
making the motion, Patty?
Yeah, I'll go ahead and make that motion.
I'll second.
So it's to direct board staff to work with legal counsel to develop language, is that what you use? To develop language supporting the use of telesupervision based on the skills of the RP temporary license holder. Okay. All right. Do we have to define, well, I guess we'll work on that. We'll figure that all out. Okay, I guess, well, we need a second?
The second.
The second, and do we need to roll call for the
Additional
votes?
comments?
Public comments? Okay, seeing none. So we'll vote, go ahead.
Aye.
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 Okay, motion is passed, so,
Oh, I'm sorry, it's a recommendation to the full board.
yeah, okay.
So, at the full board meeting, you can make the recommendation to the full board, that they direct staff to
Okay.
complete this task.
All right. I think that really covers our agenda items because our agenda did not include talking about slip of telesupervision at all. So,
Right.
so I think since there is nothing else on our agenda, we can call for adjournment, can't we?
That's good.
All right, well, we can adjourn at 1:45.
1:54, and I would like to call the meeting to order. We'll start with roll call. I'm Dee Parker, speech language pathologist.
Okay. I'm Nun Shalev, hearing a dispenser board member.
Marcia Raggio, audiologist, board member.
Patty Solomon Rice, speech language pathologist, board member.
Debbie Snow, public board member.
Karen Chang, public member.
Paul Sanchez, Board Executive Officer.
Chelsea Pruden, DCA legal staff.
Would anybody in the audience like to identify themselves? It's not necessary.
Maria Humphries, operations manager.
Okay. We have a quorum. Are there any public comments on items that are not on the agenda?
Since we put the closed session, we should probably, sorry. Is the sign up?
Yeah, I don't think we're in the closed session.
I know, but the sign is up. I would recommend to. The sign. Just- No, can you remove the sign? Just because if we're gonna do public comments for item not.
I didn't hear any.
You can go ahead and keep doing it. You can keep doing it. It's a technicality.
And can you just say that we're gonna be taking a few of the items,
That you-
a few of the items out of order?
Okay.
Thank you.
We're going to be doing a few items out of order. We have called roll. We've had public comment for items not on the agenda.
Well, let's give an opportunity for that.
There are two public comments in the board binder
Okay,
that aren't on the agenda.
okay.
So the public comment, the written public comments are provided for your review. You are not allowed to comment on them because they're not at the agenda, obviously, but if you feel like we need to discuss them at a future board meeting, you can bring that up at the end of our board meeting tomorrow. Thank you.
Closed session.
Yes.
Okay. Now we'll go into closed session. We are now back in open session, and we're moving on to number 5, where we're going to receive a report from the Office of Professional Examination Services, and this is on the 2017 Audiology Occupational Analysis. Should we introduce?
Good
Welcome.
afternoon. Hi.
Thank you for coming, and thank you for your work.
You're welcome. My name is Heidi Linzer. I am the Chief of the Office of Professional Examination Services, and I'm here to give you the results of the occupational analysis for the audiologist profession. Yeah, you might get a better view that way. So this, I have first here just an overview of the Office of Professional Examination Services, or OPES is how we called. We provide professional consulting services to DCA's boards, bureaus, and committees, and we develop your hearing aid practical exam, your hearing aid written exam, and other services for other boards and bureaus. We make recommendations based on regulations, professional guidelines, and technical standards related to licensure examinations. So we're available to do all kinds of consulting for DCA related to examination and licensure issues. The regulation standards and guidelines that guide most of our work are Business and Professions Code, Section 139, and principles for the validation use of personnel selection procedures, and standards for educational and psychological testing. B&P Code 139 requires that all boards conduct an occupational analysis for their examinations every 5 to 7 years, and the boards must submit a report every year indicating the status of that occupational analysis and also of examination development. It's designed to make sure that boards, bureaus, committees that have licensure examinations keep those exams updated. So they shouldn't be let go for years and years without being reviewed, updated, and ensure that they reflect the work of the profession. So OPES compiles that information from all the boards on an annual basis and submits it to the legislature. And our standards indicate that evidence of validity based on test content requires a thorough and explicit definition of the content domain of interest. So before we can develop a test, we need to develop a thorough description of practice, and that's what the occupational analysis is. And that's to make sure that examinations are fair, they're current, they're valid for what people are doing in the profession. In addition, a close link between the test content and the job content has to be demonstrated. So that's what our studies do, is the study provides that demonstration of the link between what goes on in the job in the field and what is tested on the examination. So licensure exams must provide a reliable method for identifying practitioners who are able to practice safely, competently, and they should focus on entry-level tasks and knowledge important for public protection. We consider examination development to be a cyclical process, so we're always in the process of doing one or another of these steps, and this is true for all examination development, not just what OPES does. It should start with an occupational analysis, as we said. The occupational analysis results in an examination outline that tells us what should be covered on the examination and in what percentage, how many items should be devoted to different content areas based on importance. And then there's writing of test questions, reviewing of test questions, and determining the passing score for the examination. And all of these things happen with the input of licensees or subject matter experts, or SMEs as we call them. So occupational analysis defines the practice in terms of the actual tasks that new licensees must be able to perform safely and competently at the time of licensure, and the essential knowledge required for safe and effective practice. And it also provides a qualitative and quantitative data to support licensure of a profession. The occupational analysis can help ensure that there are not artificial barriers to licensure by showing that linkage between what is done and what is tested. You make sure that you're not testing on things that are not being done in the field. And the occupational analysis process also improves the transparency by providing specific examination information that candidates need to know in order to be licensed. So it provides a description of current practice, as we said. It also provides the basis of a job-related, fair, and legally defensible examination. If an examination were to be challenged in court, they would look at this document to make sure that it was developed properly. It also establishes validity through linking, I said, of the content, the examination content to critical job competencies, and provides the basis for legislation and policies. It can often be useful to see what people are doing in order to make new policy or make new legislation based on changes in the profession. The process starts with telephone interviews and research. For your occupational analysis, for all of our occupational analysis, we work with the board to select subject matter experts to assist us in the process. And the first step is we make phone calls and do a telephone interview with 10 to 20 practitioners just to get an overview of the field and to get a draft list of those tasks and knowledges that that are important for the profession. Then we have practitioner focus groups, typically one or two, typically two for a profession like audiology, which has a lot of detail to it. Then we develop a survey instrument, and that survey is basically a list of the tasks and knowledges, and we send that survey out to practitioners, asking them to rate the tasks and knowledges. Then we analyze the data that comes back from the survey, and we have more practitioner focus groups to review the data and evaluate what it means and make a decision on the final examination outline. In order to achieve valid results, we need to, as I said, to have the involvement of licensees throughout every step of the process. We solicit licensees who have diverse practice backgrounds. We want diverse work settings, practice type, and geographic regions. So for that initial and interviews and the focus group, we ensure that we provide a complete and technically accurate coverage of the job content. That's the goal. We identify the tasks performed. We identify the knowledge necessary to perform the tasks. We identify demographic variables that are important that might help us understand the survey data better. Basically, people's experience, their educational background, their specialty areas, things like that. Then we develop the survey. We administer a pilot survey to make sure that we haven't missed anything. So we do that first, collect that data, and then we administer the final survey. An example of a task statement is for audiology. One of our task statements is examine external ear for abnormalities. Then an example of a knowledge statement that goes with that is knowledge of normal and abnormal anatomy of the external ear. So for your specific occupational analysis, we sent the survey to the entire population of audiologists, minus those who don't have California addresses, and that ended up being 1,541 licensees. So when there's a small number, to us that's a small number, we send the survey to all licensees. The survey response rate was 19.9%, close to 20%, for a total of 306 respondents we got back. And that may sound low to you, but that's actually a good number for this type of survey. We get anywhere from 10 to 20%, and so that's a really high number for this type of survey. Nowadays, people get inundated with surveys, and it's really hard to get them to complete surveys, so that we were really pleased with that data. So the final practitioner focus group, we evaluate the results of the survey. We look at the demographic characteristics of the survey respondents. We look to make sure, does this data make sense? And we look at the preliminary content area weights based on the data, confirm task knowledge linkages, make sure that every task has a knowledge, every knowledge has a task, and then we develop the final audiologist description of practice. So the linkage part is critical to show that every task that's performed has knowledge that goes with it, because the test is basically based on the knowledge. The task puts the knowledge in a context of practice, but basically most licensure tests are tests of knowledge. So the demographics describe the respondents in terms of experience, training, education, work setting, geographic location, provide a context for interpreting the results. You know, we can see if the results were skewed by certain practice areas. So for our occupational analysis, the respondent characteristics, the 76% hold an AUD degree for this survey. 84% provide clinical services. 77% are dispensing audiologists, and the majority reported treating all ages of patients. 12% had a master's degree in audiology, and 5% had a master's degree in communicative disorders, and 3% had a PhD in audiology. With regard to years licensed as an audiologist, we had the largest category was 11 to 20 years, and the next largest, that was 26%, and 0 to 5 years was 25%, and we're happy when we get a good chunk of entry. That's what we consider entry level, is 0 to 5 years. Typically, if we have a large profession, we will stratify our samples, so we oversample the 0 to 5 years. But because your profession, this is a small number of licensees, we sent it to everyone, so we were happy to see that we got responses from all different years licensed. The next slide shows number of hours worked per week. So most, 52% worked 31 to 40 hours, and then 28% worked 41 or more. That's also good to make sure we get data from people who are full-time practitioners. Their primary practice setting, most people, they're all over. There's a private practice, 25%, hospital, 20%, outpatient clinic, 15%. So we also like to make sure we cover all the different practice settings. Sure. Just audiologists. I mean, they could be dispensing audiologists. Right, yes. No, this is for the okay, let me go back a step. This is an occupational analysis of audiology practice only. It's the first step to make sure that your national exam for audiology covers California practice. Correct.
Heidi,
Yes.
can we clarify that?
Sure.
While it's not for hearing aid dispensers, dispensing audiologists are included in this analysis.
Correct.
Only cover their audiology part practice, not the hearing and dispensing.
From an audiologist perspective, dispensing is included.
Please use the mic. You're gonna speak.
Sorry.
And Heidi can clarify this, but from the standpoint of an audiologist dispensing,
Yeah.
that is included.
So,
Because licensed audiologists, the great majority are dispensing audiologists.
right,
So that would be included in this occupational analysis.
Yes.
but so hearing aid dispensing is part of this, the hearing aid dispensing, but it
performed
was,
by audiologists.
but it was asked only to an audiologist who is dispensing hearing aids.
Can I just say something? I don't want to confuse terms.
Yeah.
So let's talk about two things. We're talking about licenses and we're talking about the practices. So right now, the only license that we're analyzing are the licensees that are audiologists, whether they are dispensing or non-dispensing.
Yeah.
And part of that component is looking at hearing aid dispensing from an audiologist perspective. The hearing aid dispensing occupational analysis was already conducted and will be conducted again at a later time.
I see, okay.
Okay, this slide shows practice specialty in a lot of detail. The tallest bar shows diagnostic testing, then dispensing and pediatrics, tinnitus management, et cetera. So we covered a lot of, and respondents could answer multiple of these. They weren't just limited to one. So it shows that we covered a lot of different practice specialties within our respondent sample. The next slide shows the geographic region where the respondents came from. And we like to see that we covered almost all the regions. We didn't cover Shasta Cascade, but with this small sample, it was pretty well diversified. So back to the survey. The respondents were asked specifically, how often do you perform this task in your current job? And the scale went from 0 to I don't do this task, and then from 1 to 5. This is 1 being, this is one of the least frequently performed tasks in my job, and 5, I perform this task almost constantly, and it's one of the most frequently performed tasks in my job. The tasks were also rated on importance, so how important is performance of this task in your job, from not important to critically important. The knowledges were rated just on one scale, knowledge, how important is this knowledge to performance of your current practice. So when we look at the data from the survey, so the survey went out, all the people responded, rated the tasks on frequency and importance, rated the knowledge on importance. Then we analyze the data and we come up with something called a critical index. And that to us is for the tasks That's the mean, which is the average of frequency times importance. So for each task and knowledge, we multiply each respondent's frequency rating times their importance rating, and then take the mean across all respondents. So this, using this index, it allows us to capture both frequency and importance in contributing to the critical index. So tasks that are very important but perform less frequently are deemed as critical, and the same thing as tasks that are performed very frequently but not, or tasks that are performed very frequently but not important still get weight. So it's a way to use both of those categories to assess what's critical. And so the focus group evaluated the ratings for each of the task and knowledge, determined that they made sense, determined the final content area weights, and developed content area descriptions. So the actual description of practice, we had 6 content areas. The first content area was patient intake, and patient intake was defined as assessing the candidate's knowledge of obtaining and evaluating patient history, including presenting symptoms, risk factors, comorbidities, hearing and balance performance, and psychosocial and technological accommodations. So that was the first content area. It was determined to be 19% of, now what you want to think about this is a hypothetical examination outline. Because we're not developing an exam for audiology, a California exam, this is a blueprint for if we were going to develop an exam, how would the content areas break out? It's also, we call it a description of practice because we're not developing an exam. So, but these are what the weights would be if we were to develop an exam. And we asked our last focus group to break down the different content areas into sub-areas. So they broke patient intake into signs and symptoms, exposure and trauma, function, and evaluation.
So I just had a quick question.
Sure.
So I can see that the final weight is the addition of all those items to get 19%. So the individual percentages, like signs and symptoms for 6%, was that the combination of the frequency and, the frequency and importance? So
Yes,
that's
it was
what
based
ended
on
up
the data.
happening.
Yes.
Okay.
We have different methods. We typically do it based on the data, and then we let the group evaluate the data and see if it makes sense to them, because data can be affected by the number of tasks. Like you could have a lot of tasks in one area and that could weight it artificially. So we give the data to the committee and they review it and decide if it makes sense, if they need to adjust it a tiny bit. And in this workshop, for this profession, they decided that the data made sense.
Okay, interesting. So it's that frequency and importance.
Yes.
It's really interesting.
The second content area was diagnostic testing. That was deemed to be 23%. Diagnostic testing assesses candidates' knowledge of hearing and balance, anatomy and physiology, objective and subjective test procedures, and verification of equipment function and calibration. And we broke that down into preparation, behavioral, and anatomic and physiologic types of testing. The third content area was audiologic results. That was also 23%. And the definition of that content area is knowledge of test results for differential diagnoses and recommendations for treatment and management of hearing and balance impairments. And that was broken down into interpretation, recommendations, and treatment. The fourth content area was hearing aids and assistive devices. So basically, the hearing aid dispensing was a subset content area of the audiology practice. So this area assesses candidates' knowledge of patient candidacy, selection, fitting, and verification of hearing instruments and assistive listening technologies, including troubleshooting and repair. And that was broken down into selection and preparation, programming and verification, use, troubleshooting, and repair. The fifth content area was implantable devices. Implantable devices was defined as assessing candidacy, selection, fitting, and verification of implantable devices and assistive listening technologies, including troubleshooting and repair. Now you'll see that content area is only 5% 5%. We didn't break it down because it's so small. And that's a small percentage because a lot of the licensees only a small percentage of licensees are doing that kind of work. And the sixth content area was laws and regulations. And that content area assesses candidates' knowledge of laws and regulations pertaining to patient privacy, safety, universal precautions, documentation, billing, and advertising, and that came out to be 11%. So that's my information about the occupational analysis. Now I'm going to move on to the next thing that we did for the board was to review the National Audiology Exam, the praxis, developed by ETS. And just so you want to know, why do national exams need to be reviewed? That's required by Business and Professions Code 139. The point is reviewing the national examination examines whether a national exam is valid for use in California. In order to determine that, we first have to do a California occupational analysis. Your national exam does an occupational analysis, but it's national. So when they do the similar process that we do, they have people sitting around the room who are from different states. And in those different practitioners might say, oh, if there is anything that's state-specific, that's going to be left out of a national exam. You're going to say, oh, well, that's only a California thing. We're not going to cover it on the exam for everyone. So the purpose of doing a California-based OA is to make sure that we review all of California's specific practice, and then we can do a comparison with the national and see if anything is left out. And then decide if that's important enough to have its own California-specific examination. A lot of other boards and bureaus have a state-specific exam in addition to their national. It depends on what is covered on the national and what California-specific laws, regs, and practice-based tasks there might be. So, verifies, other reason to do it is we verify that professional testing standards are met. There's a lot of different vendors out there developing examinations, and we review their practices and make sure they meet our testing standards and guidelines. And as I said, we compare California-specific to the national and determine if California content is assessed. And this is part of the validation of, is this test right for your profession? So we did review the Praxis Audiology test developed by ETS. We reviewed their occupational analysis, their exam development, procedures for establishing passing score, all these things, the same things that we do for you. They do the same, very similar process, although there's a lot of different methodology. We look at their exam administration, security procedures, and what information is provided to candidates. So we did this review, and everything met standards. So we're happy to see that. Following the review of the national, we did what's called a linkage study. And that's what I was saying here. We look at the national description of practice. It should overlap more than these pictures are showing you. California description of practice should be overlapped in that national a lot, and it was. And then we look to see what's left California-specific content. So for the case of the praxis, the audiologists, the SMEs, so what we do is we have the SMEs look at all the tasks and knowledges that we had just developed in our California description of practice, and then we had them compare those to the tasks and knowledge on the national description of practice. And they had to find each of those to see if they were covered. And the audiologist determined that the content of the praxis audiology test was basically congruent with the general areas of entry-level California audiology practice. However, there were some California-specific laws, rules, and regulations that were not covered. There was about 8 tasks that we have in our laws and regs that are California-specific, or aspects of them are California-specific. However, the SMEs evaluated that information, and they did not believe that the information that wasn't covered was warranted the development of a California-specific examination. So one more analysis that we did As you probably know, in an effort to identify potential unnecessary barriers to licensure, all of our boards, bureaus, commissions have been, since the Little Hoover Commission report came out, have been asked to identify, do we have unnecessary barriers to licensure? So OPS is very cognizant of that. And because of the overlap between the audiology and the HAD practices, because we had the opportunity, we had the SME focus groups, we took the opportunity to do some preliminary investigation into the overlap between the audiology and the HAD description of practice. So we had the SMEs look at the hearing. Now, this is the hearing aid dispensing occupational analysis, the tasks and knowledges that we use for the hearing aid, written and practical. It's all one occupational analysis. And we had them compare those to the California audiology tasks and knowledges. And we also had them, and as you know, we compared the California audiology OA to the national OA. So when we looked at the results of that review, the SMEs, the only tasks that were not included in the audiology OA were ones that were specific to maintaining a hearing aid dispensing license. So we have some specific tasks about keeping your license current. So the audiologists obviously we didn't cover that on their OA. And I want to say that when we developed the audiology tasks and knowledges, we did that independently of the hearing aid test. It's really important when you have overlap, when you have different license categories doing the same type of work. For us, it's really important to get the information directly from the licensees about how they do the work. So we wouldn't say, well, we already know, like we wouldn't put on the dentist occupational analysis, say, well, we already know that you might do teeth cleaning, so let's just take all the tasks from the dental hygiene and slap them on there. We would ask the dentist, how do you do the teeth cleaning? So we asked the audiologist, how do you do the hearing aid dispensing? So there was no, so those were developed independently. However, they did correspond very significantly to be very similar. And then, as you know, we did the California with the national and found that all of the California audiology tasks related to HAD were there also covered on the national. And the next thing, we also facilitated an SME discussion during 3 different workshops to ask the SMEs about their training and experience related to hearing aid dispensing. We know this is an issue that the board looks at, and the SMEs had brought this issue up to us about the difference between hearing aid dispensers and audiologists. So in the workshops, the SMEs were both dispensing and non-dispensing audiologists. We also did a preliminary review of accreditation and curriculum standards for audiology doctoral programs to verify the information that was provided by the SMEs. So we asked the SMEs about requirements for audiologists to take the HAD practical exam, and the conclusions that we came to, or the SMEs came to from this preliminary discussion, was that the practice-related HAD tasks and knowledge were represented on the national examination. Performance-based assessments were incorporated into the curriculum in 2008, into audiology curriculum, and we did verify that by our analysis of accreditation and curriculum standards. And we had a lot of discussion about how the HAD practical examination was designed for a different population than the currently trained audiologists who go through the AUD doctoral programs. And so our SMEs were, the consensus of the SMEs in our groups were that audiologists should not have to take the HAD practical exam. But OPS recommends that the board evaluate this issue further in an effort toward making sure that you don't have artificial barriers to licensure, make sure that you can justify whether the audiologist should have to take that HAD practical exam. That's all I have. Any questions?
Board members can return to the dais for questions.
I wonder if you could elaborate a little bit more on your queries and information you gathered specifically on interoperative monitoring.
Okay, so. I understand you're looking into this issue. Interoperative monitoring was determined to be part of the implantable device content area. Did they get the report?
They haven't seen the full report,
Full report,
but it's
okay.
available to them.
Okay, so there's a task that was developed and conduct implant neural telemetry using computer software to establish patient stimulation levels. And the knowledge that goes with that had to do with, working in an operating room. And there's probably other tasks that, and knowledge that are related to working in an operating room. We typically don't pull out the different settings, but we know that some of these functions for implantable devices are done in the operating room.
Yeah, that's kind of two different things. People who work on cochlear implants and other implantable devices and their involvement with that in an operating room is kind of a different thing than interoperative monitoring, where they are looking at other cranial nerves, other neural systems in the body that have nothing to do with the ear. Did you talk to people who broke those down that way?
Okay, well, first of all, I'm not an expert in audiology, so
Mhm.
I would suggest that
Heidi,
you
if I
look
could
at the
just,
tasks, look at what the tasks and knowledge.
I think that there are also several references to related tasks, but interoperative monitoring itself was identified as job task number 45, perform neuro-intraoperative monitoring to assess neural function during surgical procedures. So in the broadest sense, it was identified.
Okay, separate and apart from cochlear implantation?
Yes.
That's true.
Okay, where are you looking?
That's on page 32 of the report. It's job task number 45,
That's right. That's right.
and it's under the area of diagnostic testing. I think there's also other, I too am not an expert, Heidi, but there are also other related areas within that section.
Okay. I'll look those, I'll look for them.
So can I speak? Oh, okay. So that was an interesting conclusion that you came up with, that the SMEs concluded that AUDs shouldn't have to take the hearing aid dispensing practical exam. So what would be the follow-up to that from the board perspective?
That's something that I think the board needs to determine. It's definitely something that we can agendize as a future discussion. But did any of the board members have any more questions on what Patty's referring to about the actual exam requirement?
Yeah,
For background purposes, for those of you that may not be familiar, sorry, Amnon, we currently have a legal requirement that audiologists have to take an exam prior to dispensing hearing aids. Specifically, it was determined at the time of the merger that requirement needed to continue until the board performed an occupational analysis and determined otherwise. So where we are now is we've looked at, when we were doing occupational analyses in the past, we were looking at hearing aid dispensing, and then we were looking at strictly audiology without the dispensing aspect. This time around, OPS looked at the broader audiology profession, which a great part of that is dispensing hearing aids. So now, in their analysis, they've looked at the examination requirements, and they've fulfilled, we're at that part in the law where it says, unless the board determines otherwise. So I think there's a couple of questions we need to ask is, what should the requirement be, and what type of exam would be appropriate? Because there is still that legal requirement that they take an exam.
Yeah. We can see it quite clearly if we look few years back and look at the result of the practical test done by an audiologist. And if we see that they don't fail, then they don't have to take. But if there is a failure percentage, it means they don't pass the exam. So why should we waive it? So that's easier than all this theoretical thing. It's really to look at, let's go and look from the time that the board merged, I don't know, 5 years? Or let's take the 5 years. We have the record, we see what's the percentage in practical exam in which audiologists that want to be a dispensing audiologist are failing. That's easy to see it.
Well, I don't think that the legislature requires us to look at past scores. I think what the legislature requires us to do is conduct an occupational analysis.
Yeah, but this is the best. So, I mean, if they fail the test,
Well, I would,
and we said,
Right.
okay, the test is too harsh on you, so don't do the test.
I understand the logic, and I think that's a logic that has been used in the past, but I would probably defer to the psychometric experts on what the requirements should be. And another thing to keep in mind is that within the scope of practice for audiologists,
Yeah.
they have been able to fit hearing aids. That the only distinction was made
Yes.
in having to do with selling hearing aids. So
There's no test in, as I know, but maybe other people will know, Marcia, maybe, if there is a test, the test audiologist in their degree in university, and there's a test on how to take an ear mold impression. That's what I want to know. If there is something not done there, then I don't know, Marcia, maybe you know if
Well,
there's.
Jackie Georgeson's going to
Oh.
address
Hi,
that.
I'm Jackie Georgeson. I'm with the University of the Pacific, AUD program. Within the standards, the curriculum standards of both ACAE and CAA, there are requirements that the programs evaluate knowledge and the skill task of taking ear mold impressions. And so the programs, it is under their scope for the programs to assess taking ear mold impressions. All students have to have that assessment during the program.
Is this something that new? Because my son done Doctor of Audiology and he never had to have a test in the university to take an ear mold impression. He's done this, but not without any testing by professor. He's done it, but he didn't have this as a requirement to pass a test there.
I also don't want to discount the research that OPS has done. I think they've looked at this curriculum. Now, one thing we have to be careful about is we didn't agendize this specific area as a topic, but I think your questions are good questions. And we're going back to the original question is like, what shall we do with this?
Yes,
Right?
exactly.
How shall we proceed?
That's what my original question is. That's a very important finding, and there was incredible time, effort, and use of knowledge of excellent experts in the field of audiology. And so, yeah, we need to decide what to do with that.
So to answer that question, I would recommend that we agendize this as a future topic, and we may need OPS to come back and talk specifically about that issue.
Of course.
Yeah. Especially on this specifically to say to us, how did you come to this conclusion?
I could provide some more detail.
Karen, did you have a question? Okay. Are there any other questions for Heidi? No.
I just want to know, I don't know if the board or you, is the dispensing audiologist taking a written exam or is exempt from the written exam of hearing a dispenser?
What was it?
An
I'm sorry, what was the
audiologist
question?
that wants to have his license changed to a dispensing audiologist, does he have to take the written test today or not?
Yes,
Yes.
yes.
I would exempt from the written, but not from the practical. This makes no sense.
So currently, today, for audiologists to become licensed to dispense, they have to take both the written and practical
Yeah, I know,
examinations.
but they put the emphasis on the practical, which more naturally that they will exempt them from the written, but not from the practical.
Well, the written covers laws and regs specific to California. They're not getting on their national.
What?
Maybe you can clarify what your concern is
No,
with the
my
written practical?
concern is that how we don't exempt audiologists from the written test, but we are looking into the subject of exempting them from the practical test.
I think we're looking at both, I think we looked at both requirements, but the background for that is that within the scope of practice of audiology, fitting hearing aids is already included, so the ear mold impression would already be part of that. The only distinction
Yeah.
is that they were not allowed to sell hearing aids, so the one would draw a conclusion that the examination would include something about selling hearing aids. And the practical exam does not include that. I think
I know.
that may be something, and
But
I don't want to get into,
But the reason
I
was.
can't get into questions, but
The reason that audiologists were not exempt from the practical was because they were 40% failures on taking an ear mold impression, like dispensers. The same, almost the same.
and I can't verify those numbers.
You have them in your
But
record.
I don't know if they were, I can't verify what they are right now, so.
I don't know right now,
Right.
but I'm talking at a time that there was a decision to have the audiologists have the practical exam.
Sure,
Was because there was a failure. That's all.
right, I understand that. I'm just pointing out that I can't verify what those numbers were at this point.
Yeah.
But we could,
Yeah, you can verify
gather
because
what
you
those
have
numbers
them.
are.
Yeah.
But at the
So-
same time that we were talking about that in the past, we'd have two audiologists take the exam at any given exam period. One would fail. That's a 50% fail.
Yeah.
And that's just skewed and invalid.
No, that's why I want to take a few years, not
Well,
one
Perhaps
cycle.
percentage isn't the best way to approach it because of that.
Well, in few years, 10 audiologists took the test and 5 failed, that's 50%. And if 1,000 hearing aid dispenser took and 500 of them failed, it's the same percentage. So I don't know, but I think now it's a little bit better, just assumption, but I still think that the best thing when we put it, maybe we'll put it next meeting on the agenda. By that time, you'll have the statistic from your record, and we'll be
Yeah.
able to discuss it.
we could definitely agendize that as an item. And
Yeah.
I think that I could probably talk more with Heidi and her staff on the correlation between examinations and exam requirements, and we could look at other professions and what they've done. But I want to be very clear on what the legal requirement is for our board, and that is to conduct an occupational analysis and make a determination based on that data. Thank you.
Can I ask if there are other, you just mentioned California-specific laws and is there any other aspect that you saw that's California-specific beyond that?
No.
Okay.
I have a question, just clarification. when you're talking about the national, do audiologists also take a national test? And so that includes like ear mold impressions and all the other stuff. So then that's why your conclusion was that they just do a written test, but not do an additional ear mold practical test for California because they've already done a national test.
That's part of it, also their education.
Yeah, then
Their
There
education
is no national
Oh, there
practical
isn't.
exam.
Oh,
No,
okay.
It's done through the curriculum of the
education.
university. They practice in the
Oh,
curriculum
okay,
of the
okay, okay.
university and are
Right.
determined to be proficient when they complete their AUD, when they meet the requirements for the AUD.
Okay.
But there is no national practical exam.
Okay, so the university itself, any university, it's one of their,
It's part of their
Required.
curriculum and their, what
Got
they
it.
need to do to be accredited.
okay. So do all universities have this standard or?
to be accredited, they do.
Oh, okay.
That's what we have.
No more questions? Are there any questions or comments from members of the public? Okay, no?
Yeah, we have here one cycle, and out of three out of three audiologists, 2 passed and 1 failed. So but this is one cycle that we have here in tab 11D. And we have 2 hearing aid dispenser, 1 passed and 1 failed. So, but this is only one cycle. We have years all the way back. So we can see. So if we can say, look, let's say, I'll take this one. Let's say 30% of audiologists who take it fails. Then we can say, okay, we'll take this risk.
Yeah, I understand what you're requesting. It's very clear to me what you're asking.
Yeah.
And I think that we need to agendize this so that we get, appropriate input from others that are interested, and that we look closely at what our legislative requirement is in this area. Thank you.
Thank you.
Thank you.
Thank you.
Thanks, Heidi. I think we can go back to reviewing the board minutes, if we have to. We are now at 4:10, so we have time to at least review the board minutes.
The board minutes, okay. So at this time, this would be review of the minutes for February 8th and 9th, 2018. Okay.
I have a couple issues. Or do you want to go page by page or?
Sure. Yes,
Okay.
but we're not doing edits, right? I've got the typos written and can just give them to somebody.
Okay.
Okay.
Are we sure we have the same ones? Okay, I just have a general comment on looking at item number 15. For example, that's page 5. Whoever typed this up kind of conflated the idea of an AUD and an audiologist as though they're one and the same thing. And they might be, but it often says AUDs are the only profession who has been trained for decades to read brain waves. Well, there's 2 problems with that sentence. Not every audiologist who does that is an AUD, for one thing. So they're using that degree designation rather than the term audiologist as though they're interchangeable, and that shouldn't be the case. It should just flat out be audiologists and not that, unless they want to say something specific about AUDs. The only profession who has been trained for decades to read brain waves of nerve responses. There's just a whole lot of problems with that sentence. because they read neural transmission from a number of different systems that could be in your leg, for that matter, not in your spinal cord. It isn't always brain-related, but they are looking at electrical activity in the body, some aspect of any ongoing EEG that they can extract waves. Trained to read neural responses is probably better than saying reading brain waves, okay, because it could be from anywhere in the body. And that paragraph and the next one down turns in motion, develop a letter supporting AUDs in their work performing interoperative monitoring, again, should just be audiologists. Lots of interoperative monitoring folks have PhDs, so to call them an AUD is already a problem. So I don't know how you change that, but I would just substitute
Just change
that.
Call them
it to
audiologists.
just audiologists.
I mean, in these particular minutes.
Yeah.
Right.
Okay.
Okay. I suppose at the top of that page, Marcia, I should clarify. Item 13, describing it, one date, January 11th, 2017, and right below, January 11th, 2018.
Yeah, it was 18.
18, okay.
You got that error in that fourth sentence down? No longer wanting. Is that a typo?
The what?
Is that a typo we shouldn't be discussing?
Was there anything else, Marcia, related to that? Okay. Any other comments on the minutes? Okay. Then. Then do we have a motion for the minutes?
I move to approve.
I move to approve the minutes as, yeah, with changes.
I move to approve with changes as recommended by the board.
I second it.
It's been moved and seconded to accept the minutes with changes. Is there any further discussion from members of the board? Okay, any comments from members of the public? Okay. Then let's call the vote.
Yes.
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 Okay. Now, where would you like to? Here?
We can, if you would like to go into the executive officer report, which was going to be covered tomorrow.
Okay.
It's up to the board if they want to continue. I'm handing out my written report right now. I'm late in turning in my homework to all the faculty on the board. Yes.
Cost you points.
Yeah. Lots of
Right?
points.
At the very least, it'll cost you points.
Here's some copies for you. So it's up to the board if they want to go over this today.
Okay. So, board members, would you like to review this report? No?
Yes.
Okay.
Is that a yes?
Yes, they did.
Okay, and I just lost Brianne. But I think she's going to come back.
Oh, she's
Well, first of all, I just want to thank everybody for their patience. This has been a somewhat challenging time. We've experienced some staff turnover, and while that is good news for those that have moved on and gotten promoted and advanced their careers, it makes it difficult for our board office when we have such a small staffing situation already. So, as you recall, we were successful in obtaining 2 additional positions that are going to begin working at the board office, or that will become effective July 1. So we have those vacancies that we were planning on filling in the month of June, which is coming up in a couple days, if my dates are correct. And we have tomorrow. There we go. And then we have our 3 vacancies. So we have 2 vacancies in enforcement and 1 in licensing. And we are in the process of filling these positions. So Brianne and I have spent a lot of time in hiring interviews. Those of you that are part of public or government agencies and have been part of the hiring process, I'm sure you are well aware of how challenging that can be. There are a lot of steps to take in the civil service hiring process, so that has taken up a lot of our time. That's why this is a hand carry today, as opposed to being part of your binder, so I apologize for that. But we are looking at filling 2 positions in enforcement and 1 in licensing. I think we have a final candidate for licensing and possibly another candidate that we're looking to hire in enforcement. And we might be able to get a live update right now from Brianne on where we are in the hiring.
Oh, wow.
But we're going to require you to come up to the microphone. So I told them about the 2 BCP vacancies we're going to be recruiting for, and that we are currently recruiting for 3 board staff vacancies. So the 2 enforcement and 1 licensing.
And I'm happy to report that Monday, we've got an SSA licensing candidate that's going to be joining our team. And real happy to report that we are promoting Tim Yang, who's a current licensing analyst, Monday to the enforcement position. So we're really excited to report that.
Yeah.
I hired Tim in as the OT, the office technician. He did so well, then we promoted him to a licensing analyst, and now he's going into enforcement.
Okay.
So he's well-trained.
So if Tim Young is promoting, who's going to do our travel expenses?
Tim helps out in all areas.
We'll do this.
Yeah, he's real good. In fact, he's ordering your lunches right now.
One of the things that we tell people when we hire is that everybody in our office does a little bit of everything. And enforcement staff, I mean, Carly can tell you, she's been involved in exams, she's been involved in a little bit of everything. So we're kind of like a small business. And thank you, Brianne. That's actually great news. Exceeded my expectations.
So then who's going to take Tim's spot?
I'm starting to recruit for that right now as well.
Okay.
And the recruitment process, just so you know, it's very lengthy.
Yes.
So I spend a lot of time going through applications online. I think for the position Tim just got, there were 175 applications.
Wow. So
We will have 2 existing vacancies, and then we'll have 2 more positions to fill.
Yeah.
So we'll be busy for at least the next month and a half filling positions. I think that's the nature. Having worked for the last 10 years with the Department of Consumer Affairs in board office, I think that's what you find. It's a rare opportunity to come into a work setting where you attain knowledge in the administrative adjudication process, in licensing, in enforcement, other state administrative processes that include budgets, regulations. Where else are you going to get all of that in one place. And I've been a career government employee for 30 years, and I haven't found a place where you can get that much experience in such a small amount of time. So hence you have these people that are promoting quickly. Thank you, Brianne, appreciate it. Within your budget report, we have included the expenditure projection report. And our department has been going through a conversion process into a new system called, I was getting confused with the old one, it's called Fiscal. And it has been a challenge for them, but they have, our budget office does great work, and they have worked with us and helped us crunch our numbers. And it's allowed us to move forward on some other projects that we have, such as looking for additional office space for our board office. So as of right now, if you're looking at the fiscal month 10, 2017, 2018 budget report, fiscal month 10 means that is through the month of April. In every budget year, there are 13 months. Fiscal month 12 would be through the end of the month of June, and then fiscal month 13 is a reconciling month where you go and you finalize the books for that year. But based on our current projections, we are looking at spending most of our money and ending up with about a $50,000 surplus, which is good because that means we're busy and we're working, and it's cutting it pretty close. I think that we're in pretty good shape right now. As you can see, there are those areas that are in parentheses, you don't have a color copy, but you can see those areas that are in parentheses are the areas in which we overexpend. Are there any questions on our expenditure projection?
When you come up with a surplus, does that interfere with the plan to increase fees, or not interfere with it, but mitigate it in some way?
It can. It can. And what the surplus does is the surplus goes into the board's savings account. For lack of a better term, it's our savings account. And you want to have a reserve because you may need that reserve in a situation where you have to expend more than what is in your budget allotment. But in this case, $50,000 is not a lot of money.
Yeah.
So I think we're in pretty good shape there. We are also looking at some other future projects. We are in the final phase of the Department of Consumer Affairs converting to a new database. So that's something that is going to cause us to have to expend additional money to build that database for the board. We're still using a much older platform. It's a green screen legacy database, and eventually, we want to move on to a newer platform. In addition to that, we have been working with the Office of Information Services, and we expressed a need to have online renewals. At a minimum, we want to allow our licensees to be able to renew online. I always joke when I speak publicly to these groups that we are probably the only reasons why they order checkbooks or postage stamps, because they have to renew with us by snail mail, and that's probably the only thing, I know for my wife who's a licensee, that's the only time she ever uses her checkbooks or postage stamps for that. So we want to get to the point where we are able to renew online, and there's going to be a cost associated with that too. All these things, are part of our future projection when we look at our fund condition. And we are moving forward with our fee increase, and we're actually currently in the process of working with budgets and working with our legal office, and I think Kelsey's working with us on those. So we're actually reviewing the fund condition, but that's a great question. Very long answer. Yeah, great question.
I raise a question that I raise, I think, almost every year. When we're talking now about the budget, when are you going to put all the emails of all the licensees in the database so we can communicate with all the licensees via email? And it's voluntarily, of course. You can ask the licensee in the renewal if you want to be in contact with the board, it's an optional, put your email and we will send you messages.
We actually, we may have understated how much we communicate with our licensees by email, but most of our communication in our board office,
Yes.
from examinations to licensing
Yeah.
to enforcement, I want to say 95% of our communication is done electronically at this point. The only
What do you
time
mean
the only time we communicate with our licensees
Yes.
through official U.S. mail
Yeah.
is when we have to legally notify them of something. Otherwise, we are actually communicating. So we do gather emails for that purpose, but we can't require it, and I think that's what we've said in the past.
Yeah, you cannot require
Right.
it. It's only voluntarily. But I think majority of the people will not mind that they'll get
Right.
notification. Let's say if you have very big cases that have been resolved, a settlement or something like this, you can send to the people.
We also have, and we also gather emails to our interested parties list.
Yeah.
So the point I'm making is I didn't want to understate that maybe in my previous answers, because we actually utilize email for most of our communications, a great majority of our communications with licensees.
Via email?
Absolutely.
Do you have-
Katrina Martinez, who is
Do we?
working,
How many we have emails? Do you know?
well, what percentage of your
Approximately.
communications are through email with licensees?
Oh,
I can attest that
how
all
did
the-
you get them? How did
All the applications that come in, I see them, there's always an email on
you know
address on.
the new applicants?
Yes.
Oh, but what
And that's how
about
we communicate.
what about the dinosaurs?
Oh, like you?
Yeah, like me, yeah.
We collect them. Most of them will email to the speech and hearing board.
The email?
Yes, and then we capture their email and we communicate with them that way.
Okay. So we got it.
So we-
Now we have
We
it.
are doing well that
We
way.
are doing, and I think what we were addressing in the past was the requirement, because this has been a discussion throughout DCA about requiring emails, but I wanted to be really clear that we are actually working with the emails that we get. And most of our communication and our workload isn't with existing licensees, it's with the applicants, and it's with mostly just applicants.
Yeah, I know, but if we want to send a survey, let's say on an issue, I never seen a survey by email. Usually you go to the association, which they have their members, HHP
Right.
and CAA, and if we have this 90%,
And
We can-
and the way we do that is we have an interested parties list for people to sign up and
Yeah.
provide us with their emails for those existing. But we have been actually really successful, even as pointed out by Heidi Linzer-Hill in her occupational analysis, a 20% response rate by existing audiologists. That's a pretty incredible number. That's twice the norm.
no,
About
that's,
3%.
that's good. It means they're responsive, but I think they send the survey by mail, right?
I believe that was done electronically.
It's electronically.
Yeah.
We send an invitation out to all the licensees, letting
Yeah.
them know about the survey. And
I don't
then
know.
if they're
Did you get the
interested,
survey? Here she is,
Not that I recall.
audiologist. She didn't get the survey.
Well, she didn't participate in the survey.
No, I mean,
I don't recall getting it.
not,
We used to be able to buy, that is, we meaning professional organizations, could buy the address list for various announcements and so on. Do you ever foresee being able to buy an email list?
You know, I'm not sure about that. I'd have to look into that. I don't know, and I don't know how valuable it would be. So I'd have to I don't know enough about that to answer that question. Moving on to licensing, exams, and enforcement, the next page after the operating expenditure projection is our licensing report. And what we're looking at here is number of licenses issued in each category through the third quarter. So at this point, we are we are experiencing growth in the number of licenses issued. You can actually see that just by looking at the number. We're already at 3,000 through the first 3 quarters, and we're actually going into our peak season. And, just to point out, our licensing staff have done a pretty incredible job at staying up to date during this time. We actually have had a vacancy for a few months, and, we've always relied heavily on Tim to keep licensing moving. Now we rely, I'm putting Katrina on the spot, sorry Katrina, but we rely heavily on Katrina, who is working with Tim, and she's kind of held down the fort too, along with Tim. And I just want to commend our licensing staff, they've done a great job. As you recall, the application process and the long waits was always a sore issue with our board office, and over the years, we've made great improvements there. On the second page of my report, you can actually see the timeframes, and I kind of give you just a snapshot. If you look at 5/1/18, you see that we're within about 1 to 2 weeks in every process, and we're exceeding our performance measures in each of those areas. Back to the materials that were sent to you, the second table is the licensing population. So you could see continued growth in the area of our licensing population. We're at a total number of 29,000 at this point. The next page are the results of the February 24th, 2018 hearing aid dispensers practical exam.
Yeah, I found out here, this is a note for the previous subject that we have. There were 24 audiologists tested, 3 failed, 27 and 27 hearing aid dispensers, 6 failed. It means 10% of audiologists failed and 20% of hearing aid dispenser failed.
So
This is just
Yeah.
of this
Right.
one. I combined all the numbers, so we can look backwards for a few years.
So these are the exam results for the February 24, 2018 exam. Does anyone have any questions on the practical exam or on this report now that we're talking about this? If not, then the next page is a summary of our enforcement statistics. As you recall, we said that at the year end, we're going to break up the speech and audiology statistics. So I'm preempting your question.
All right.
And you're going to do that when?
Right there.
Yes. But as far as enforcement goes, our numbers are actually growing. The number of complaints have increased. The number of convictions received have also increased. We're still handling intake at a normal rate, and our investigations are actually seeing some improvement, and not much has changed as far as average days to discipline. I think we're at right now about 750 days, which is about the equivalent of about 4 years. Now, just to make sure that everybody has an understanding of what that means, typically disciplinary cases take about 3 years. Investigations alone sometimes take about a year, so it's not unusual for them to take about 3 years, and 3 years would be a good, kind of a good time frame. But we have a relatively small number of cases, so one case can make all of our statistics kind of seem a lot longer. We have some old cases. I think we've moved through most of our old cases that we inherited from way back. So I think we're moving along pretty well on these cases at this time. We currently have 16 formal discipline cases pending with the AG's office, and we are monitoring 31 probationers. 8 of those probationers require drug or alcohol testing, and 10 of those probationers are in told status. I've also included just a table that shows you all of the licensees that you have disciplined during this fiscal year. On our board website, we have listed all of the licensees for previous years, if you're ever interested in seeing that. Are there any questions on my report? I wanted to mention one other thing. I'm sorry. I mentioned that we were short-staffed in enforcement, and this is kind of good news. We partner with a lot of different business areas at DCA, and one area that we partner with is the Division of Investigation. They have offices here upstairs, and they help us in conducting investigations. They're our law enforcement arm. And at times, we've been able to work with them and tell them, hey, we're in dire need here. We have, our workload is piling up, and because of our vacancies, we can't necessarily get the work to you. So the concern is that at one point, the work would bottleneck to them. So I spoke with David Chris, who's the chief over DFI. We call them DFI, Division of Investigation. And he has been working with me, and they're actually helping us out. They're loaning us staff that are going to come in and help us go through the cases and keep the cases moving. Because that's one thing this board has done actually very well, is our enforcement and discipline program has just gone really well. And we don't want that to suffer because of these vacancies. So I just wanted to express my appreciation to Department of Consumer Affairs and DFI for their help. Are there any questions on my report?
So when is it you're going to separate street pathology and audiology?
At every fiscal year end report. So the next board meeting, you'll see some numbers. Right, Brianna?
Didn't I? I could have just left that.
And when we have our new database, that'll all be separated automatically, so. That's all for me. Thank you.
Thank you. It's 4:40.
I think we should. What do we call it? Yeah, so we're just going into recess until tomorrow.
Do you have any public comment on the executive officer's?
No. Any public comment on the executive officer report or any of the board reports? Okay. So we can adjourn until tomorrow.
Okay. All right. We will be going into recess, and we'll see you again tomorrow morning at 9 a.m. right here. Thanks for being here.